TopMedTalk.
Well, hello, it's Anesthesiology 2022 here in New Orleans, Louisiana. TopMedTalk is here in the exhibit hall, booth 2245. Excited to be here, another buzzing exhibit hall. I'm Desiree Chappell. I'll be your host today, and I'm joined by my co-host, Professor Monty Mythen. Hello, Monty.
Great to be here, Desiree. Great to be. I was just reflecting on where we were for our first ASA.
Yeah, I wasn't there.
Oh, you were. That's why.
Thanks.
That's why I couldn't remember what happened. So that must
because I wasn't here to remind you.
That must have been Boston.
It was Boston.
So that's the only one you weren't at. But so welcome, Desiree, to the TopMedTalk.
Thank you, Monty.
So you've been with us. That must have been you've been with us 4 years and 364 days or something.
That's correct. But 5 years at the ASA. Every meeting that they've had, we've been here, haven't we?
Yeah, absolutely. Yeah. Including when we weren't here.
Yeah, that's right. We were kind of here when we were
COVID.
Well, Monty, this is an amazing booth,
Beautiful.
Isn't it? Like, this is the evolution of where we've been. I think we started on the corner.
We did. We had our very own table to start with. And that seemed to work okay. And we've evolved through some lovely booths over time. But this is the pinnacle. We've reached the pinnacle.
Yeah.
So we've reached the pinnacle for now.
But that's right. There's always more to come. Well, we do want to thank the American Society of Anesthesiologists for supporting us to be here and the generosity of providing us this space. It's absolutely amazing. The live stream as well. So you may be watching at home. If you're not, you're listening to this over the next couple of days. We actually are live streaming this entire event. It's at live.topmedtalk.com. That's live.topmedtalk.com. Check it out if you're listening. You can find all of our conversations that we are having throughout the meeting. The schedule is there. If you missed anything, you see the schedule and you missed it, you can go to live.ebpom.org. That is EBPOM, EBPOM, which is Evidence-Based Perioperative Medicine. Tell us just a little bit about that real quick, Monty.
25 plus years ago, after I came back from Duke, which we'll talk about in a moment, to return to the UK to take up my position at University College London, I was hearing about this perioperative medicine thing, and we decided that it was the future. So we set up this conversation about evidence-based perioperative medicine that turned into a meeting, first in Ireland and then in London. And from then, 25 years later, it's lived on. EBPOM is a global presence. We have meetings around the world. London, Ireland, USA, Singapore's coming up in December. If you want to go to Singapore, EBPOM, Asia Pacific.
Right, very good. You can find it there. Yeah. You can find all of our previous conversations, which we have worked with our next speakers, GE Healthcare, in the past. You can find those at topmedtalk.com, so do check that out. But without further ado, we definitely want to get into our conversations today. And it is with my great pleasure that we introduce our guest. We have Dr. J.W. Beard, Eric Ruedinger, and Dr. Guy Deere. Gentlemen, thank you so much for joining us.
Thank you for having us.
JW, I'm going to start with you first. Tell us just a little bit more about yourself.
So I'm an anesthesiologist. I'm the Chief Medical Officer of GE Patient Care Solutions, which is one of the businesses that exists in GE Healthcare. We're the acute care business, essentially. We're providing technologies that are used predominantly in hospitalized patients today. That includes anesthesia delivery, patient monitoring, diagnostic cardiology, maternal infant care, some digital health products. And it's for our anesthesia business that I'm here supporting GE this weekend.
Yeah, we see GE. They're very prominent. That's great. Yeah, that's wonderful.
And one of our biggest sponsors.
They are a wonderful sponsor. Thank you so
Absolutely.
much for all the generosity that you guys have shown us over the years, for sure. Now, Eric, why don't you introduce yourself?
So Eric Ruedinger, I work closely with JW. I'm the general manager for anesthesia and respiratory care within the patient care solutions business of GE. So I've been in this job for a little over a year.
Okay.
So relatively new to acute care and anesthesia.
Yep.
Spent some time in cardiology before then.
Oh, very good.
But
okay.
Thanks for having us.
Well, actually, what I have to highlight for Eric is not only the wonderful conversation that I'm sure we're about to have, but you got to show them your shoes.
They like
those
the shoes.
Those are amazing Chucks that are GE Chucks.
Yep.
GE Healthcare.
Yeah.
You know,
is that what Chucks is?
We're in the process of
Converse
of spinning out as a public company. So these are just a subtle little nod to the compassion purple that will be GE Healthcare going forward.
So that's a subtle bit. GE Healthcare.
Yeah.
Got it. Okay.
Yeah.
I was
With
just
a
looking
capital
at
C.
the color and the GE bit.
Okay, I'm going to
We've got
tell
it
you,
now.
if you want to win me over forever.
A pair of those? What
a pair-
size?
a
What
pair of
size?
those. I can't tell you on camera. Are you kidding me?
Can't disclose it public.
That is not.
She's under contract.
We'll work that out later.
Oh,
No
of course, thank you. And our last guest, I want to make sure we have a chance to talk to you. Dr. Guy Deere, thank you so much for joining us.
You're welcome.
Yeah.
So I
go a long way back with this gentleman to my left, about a quarter of a century, actually, I think. I'm a pediatric anesthesiologist at Duke, but you can probably tell by my accent that I trained in the UK at St. George's and Great Ormond Street Children's Hospital, and then came over to Duke, and I've been there for a long time. But was excited to work with GE on the project looking at end-tidal control, which we'll get to talk about in a minute, I'm sure.
Yeah, absolutely.
So Guy, we're going to talk about low-flow anesthesia, I think, as part of what we're going to discuss.
Yes.
Which immediately brings me back to the old hospitals in central London. We worked at different ones, but they're pretty much all the same. And, they're giving volatile anesthetics, rotameters, and high-flow anesthesia. So the gases were turned up high to try and keep the patient safe. The vapors were flowing. At that stage, they were escaping into the environment. We were breathing them in as well, which wasn't very good for us.
Right.
And eventually those things got better and better. And we started to work out ways of taking the carbon dioxide out of the circuit. And the flows we thought could go lower and lower. And certainly in our department, or every department I worked in, there was one enthusiast, usually, for low-flow anesthesia. They stayed through the whole of their case, and they said, if I can get the knobs right down
the lowest
to
possible.
a level, and I can absorb the carbon dioxide, I just have to give enough oxygen that matches the oxygen consumption, and I can get down to a few hundred mils. And we'd go in and say, that's great, not giving any names away, John, if you're watching. Great, John, that's really fantastic. I'm going back into my room and turning them back up because that's just too hard. Is that the world that you grew up in as well?
I definitely remember that scenario, absolutely. And there was always one or two people doing this crazy stuff. And it seemed to be too much on the edge and
just
too scary.
Yeah, too scary. And then suddenly, it happened earlier in the UK than it happened in the USA. These new anesthetic machines arrived. And you said, I want the oxygen level to be that, and I want the vapor level coming out of the patient to be that.
Yes.
And it just happened. And now the younger people who've trained in Europe don't know that there's a different way of doing it. But I'm thinking this is just more recently happening in the USA. Is that right?
No, it's really just a brand new concept, and we're kind of excited that it's finally here. Again, talking to colleagues in other countries, we have good experience looking at these devices, but now it's finally available in the US, which is great.
It's so brilliant that as I say, we grew up through it. So, in the same way that we didn't have mobile phones and the internet and things like that, the youngsters in Europe have thought this is just normal, that you hit the two buttons. So they say, well, it's not exciting. Well, it is exciting if it's new to you. And it makes life easy. It's great for the patient. You can get the depth of anesthesia right. And really importantly, it's good for the environment is a factor that we're discussing there. So please tell us more about that. I've done a lot of talking. That's one of my problems.
Well, and actually I was going to ask you, Dr. Beard, just walk us through a little bit about low flow. I mean, I know they went through that, but, from what we've been seeing in the past and maybe, where we're going.
Yeah, so I think to start, low flow, I think is historically had many different definitions.
Yeah, I was going to ask.
There may be definitions
what does it
based
actually
upon
mean?
the percentage of the patient's ventilation, or is it a percent of rebreathed gas that would define low flow, or is it a specific volume flow threshold, like less than a liter per minute, or is it something that's more physiologic, like low flow is providing the amount of oxygen that patient is requiring metabolically per minute? And I think where it sorts out is probably going to be along the lines as recently discussed in the APSF newsletter. It's kind of getting towards that physiologic match, but making sure it's within the provider's level of comfort.
Yes.
In terms of where they're comfortable with the flows being set. I think the challenge with low flow is that it does require significant amount of vigilance compared to the traditional free gas flow methods of really just putting in a ton of gas and not needing to adjust those flows over time. But really with low flow, outside of an automated system, it does require constant vigilance to your oxygenation and your vapor levels because the inhaled anesthetic uptake changes throughout the course of the case.
Oh, okay. Very, very interesting. Because that's what I was trying to break down in my mind. Like, as an anesthesia provider, go in, like Monty said, turn the gases on, crank it up, and you're just set for the entire case. That.
For everyone who's not in this or didn't live in that world, let's just concentrate on the oxygen for a second.
I would say turn the oxygen on.
Turn the oxygen up to a
2 liters.
Nice high, or
3
a
liters.
nice high number.
Yeah.
to say that's a nice high number.
5
The patient consumes maybe 250 mils, let's imagine,
Yeah.
70 kilogram person per minute. Everything that isn't that 250 mils is gone.
Gone, yeah.
So that's a waste component of it. Coming out with the gas is the carbon dioxide.
Mm-hmm.
So if you can put it into which we've been able to do for centuries now, if you put it into a closed system with a carbon dioxide absorber in it,
Yeah.
you can reduce the flows down and down and down and down. But before you computerize that and automate that and get some smarts in it, it's potentially a more dangerous game because you're close to the edge. But we're going to tell us you've solved all of that now. I'm guessing that's why we're here.
Yeah, and I think that and it's not just kind of the observations from the clinical trial that Guy and his colleagues led, but it's part of the evidence that's been published from international locations where this type of technology is available, and it does an excellent job, an outstanding job of attaining and maintaining the set anesthetic and oxygenation targets. And so if you think about the beginning of a case, for example,
Right.
maybe the busiest time for the anesthesiologist, or the anesthesia professional, the patient's airway is secured, and now that person who may be alone is expected to get another line in, help position that patient, etc. The whole time while the patient's volatile anesthetic uptake is at its maximum.
Yeah.
And so you end up with kind of a higher flow, a higher administration level of anesthetic. Next thing you know, 10 minutes later, you've got your line in, you turn around, that patient's hypotensive.
We have blood pressures in the tank.
Because at that point, the anesthetic level's a bit higher than you wanted. Maybe you've got sterile hands at that point, and technology like in-tidal control enables the anesthesia provider to set that level.
Mm-hmm.
So, for example, 1 MAC of whatever inhaled agent you're using, and then you can get to work on things, and the machine will keep that patient at 1 MAC based on that in-tidal level.
So it's a form of autopilot or fly-by-wire. I'm sailing my ship, I need to do whatever.
Mm-hmm.
Hit autopilot, hold the course. I'm flying the plane, I need to do whatever. Hit autopilot, I maintain the course. Cool.
Yeah.
Beautiful.
That's right.
Beautiful.
And so, like, as you're, if you induced your patient, you're going to have a little hypotension. Sometimes we don't crank, you don't turn the gas on, or you turn it on a little bit lower, and hoping that it can come on a little bit more slowly. Is that all automated in this as well? Is the rate of obtaining that particular MAC?
Yeah, and Guy, I'd be interested to hear your experience at this point, because the induction period, there is a lot of change that goes on in induction.
Yeah.
And certainly technology like in-tidal control clearly does an amazing job during maintenance, but I also think it has applicability during induction. Guy, do you recall how you used it during induction?
And emergence.
Yeah.
So,
Okay.
Obviously, we like the patient to wake up swiftly and safely at the end, so it does help dramatically with purging vapor and getting oxygen safe. But at the beginning, the provider can set the levels that you think are appropriate. The device will get to that set point within about 90 seconds very quickly, and then ramp down so the flows will drop and the agent will drop automatically, and we'll get to the new set point. We talked about a high flow during induction. That's obviously sensible. We want to get the number of molecules of inhaled agent into the patient, but once we've got there, we don't want to overdo it.
Right.
The flows will cut down to the basal level, which might be 0.3 or 0.5 liters per minute, and we're now cruising at a safe and controlled fashion, and not much is going out of the door.
That is incredible. I mean, as a clinician who struggles with that every case, thinking, that you can have something that you do, because, I mean, there is a time period of right after induction, you're already worried about that. You don't necessarily want to, dose them up with vasopressors until you know what the blood pressure is. I mean, there's a lot of things that we can unpack on that. That's really, really interesting. JW mentioned that there was a study that you did. Can you walk us through a little bit about that?
Right. So this is a multi-center study in 4 different institutions, and we had patients who either used the new device or just kind of standard anesthesia practice, and we compared and contrasted how they got on. And the interesting thing was that with all of the patients who using the new device got to their set points very quickly with not much overshoot, and basically tracked along exactly the concentrations that were desired. So we looked at that, comparing it with the manual practice, which, to be honest, was not that great. When you watch what people actually do in the OR, they're either fiddling around trying to control it manually, not doing a terribly good job, or perhaps being busy doing other things, not having time to adjust it. And we found that the manual control was really fairly poor, whereas the automated device was amazingly accurate all the way through, whether it was going up in concentrations at the beginning of the case, changes in the middle when more stimulation perhaps, or then particularly at the end when you want to come down on your agent, it would get rid of the agent very rapidly.
It's not undermining the clinician, it's enabling the clinician. So you choose the
concentrations.
The target.
Yes.
Yeah. Okay.
And that, to me, that was the beauty of it, that it enhanced our ability to get to the set points that we desired, rather than hunting around trying to pick a place to go.
Yeah, that's interesting. So, question. You just mentioned that you would have these crazy people come in and change all your flows, and then you change it back as soon as you came in. What is the adoption like? What did your colleagues and the participants in the study kind of talk about that? Was that one of those moments, or was it like, wow, this is actually really useful?
I mean, we had a lot of comments, and we asked people to be free and honest about what they thought. And the vast majority, I think it was about 90% of people said they really, really liked it. And one comment sticks in my mind, which is set it and forget it.
Yes.
And that, to me, is really helpful, because I know and I have confidence that when I choose that concentration, it's going to get me there and it's going to stay there, and I don't have to worry about changes.
You can just if you think about the experience outside the United States too, obviously there were four centers.
How long have you had it for in the UK?
I think
the automated systems.
Slightly more than 10 years.
Exactly.
I was 2011 or 2012.
I don't think anyone does it the other way now.
Right.
Yeah, that's right. That was my point.
That's kind of like,
why would
really?
you?
Almost 100. It's almost 100% adoption. So
okay.
it's like standard of care in Europe.
And was that a pretty widespread adoption pretty quickly, or it was like, wow, this is a game changer?
Yeah. Part of the reason there was a delay of a decade between Europe and here in the United States is so the end-tidal control software is a Class 3 medical device.
Yes.
Yeah.
And so the clinical studies Dr. Deere was referring to, are ultimately tied to the PMA process. So, a lot of credit goes to Dr. Deere and the other centers in this study, remaining persistent in the process of demonstrating to FDA that this thing that was out there in Europe and standard of care, met the thresholds in this country for us to be able to bring the technology to market here as well. So,
So where, remind me again, when did this technology get approved? It's been around here in the
in
US?
the spring, so in late March,
this year.
very end of the first quarter of this year.
Okay, all right. That's really interesting, because I would love to know, like, where is it right now, and what's the penetration? I know as we're going beyond and looking at anesthesia machines and things like that, the options that we have, there are a lot of options out there.
Yeah.
This sounds like kind of a bit of a game changer for you guys.
Yeah, we definitely think so. We're really early in the launch process, if that makes sense. So obviously, if you come over and visit our booth, you can see ET Control in action. We have live agent over there.
Cool,
so
we'll do that.
You can see it in real life, but we'll get to begin the commercial rollout of this here in the last couple of months, and we'll see that really gain traction, we think, over the course of the next year or so.
Yeah, fantastic. Any other points that you guys wanted to share about that new technology?
Yeah, I mean, I would just, my initial reaction to seeing it in the simulated environment was like, that's it?
Yeah.
Like,
it's
like I heard about it. I'm like,
That's
oh my
right.
gosh, like we're finally going to have this in the United States. And it is the technology underpinnings of it are so robust and it performs so well. But the anesthesia provider's end of it, it really is just establishing targets for the end-tidal anesthetic, targets for the end-tidal oxygenation, and then going about your business and doing the other parts of patient care. It doesn't add a technology burden to the anesthesia provider. And by removing those repetitive manual tasks associated with delivering low-flow anesthesia, it's really remarkable.
Yeah.
And I think there was a question about the environment earlier.
Yeah, that's what I was going to
It makes
mention.
a big,
Yeah.
big
The value
difference.
proposition here regarding the environment.
So it facilitates low flow anesthesia and lower inhaled anesthetic use. So there's less waste.
Because you
And
recycle the agent as well. You don't waste the...
That's
the
exactly
ingredients.
right.
Yeah.
So there's inhaled anesthetics are potent greenhouse gases. And there have been some studies that estimate the carbon footprint that comes from anesthesia delivery within health systems. I believe there's some data from NHS actually, which
Yep.
attributes a substantial portion of their greenhouse gas emissions to anesthetics. So it's by supporting low flow and reducing anesthetic waste, it has that favorable environmental impact, and then lower anesthetic use is lower cost as well.
And Guy, Dr. Deere, is the study published now, or is it pre-publication?
Well, we have a poster presentation at the ASA today, and
Great.
we're having a slide presentation tomorrow, so
Excellent.
it will be published, and we're looking to write this up more formally for a journal submission
Excellent.
in the near
Yeah.
future.
Choose
forward to that.
well.
Yes, yeah.
Watch the slides tomorrow.
Excellent. We're looking forward to it.
Yeah, so just wrapping up, guys, value proposition of this new technology. The technology is in title. Say it for me one more time, Eric.
And title control software.
In title control software, that's right. And value proposition for that, definitely ease of use for providers. I think that's a push it,
Yep.
set it, and forget it.
Forget it.
Greenhouse gases, and I would assume patient safety.
Oh, yeah, of course. Yeah, you guys should speak to that.
Yeah, Dr.
Right.
Deere.
I mean, I think the ability to have this device helping you get to those set points quickly and safely definitely makes the provider more confident that what they deliver is what they want and what will be appropriate for the patient.
Yeah.
And it changes very fast, which is also fabulous.
Yeah, absolutely. Gentlemen, it has been a pleasure. Thank you so much for sitting down with us on TopMedTalk to talk about this really cool, new, interesting technology. And thank you for wearing the shoes, Eric.
And
Super
we'll figure that out.
So GE Healthcare,
Yeah.
what's that all about then? I've just noticed that I think
Yeah.
you touched on it a little bit before. It's a new thing.
We'll
Well,
be
G-
an independent company. Go ahead.
Yeah, so GE announced a while ago that it's splitting into three separate businesses. So GE Healthcare will be the first of the GE businesses to ultimately go out on its own.
Excellent.
We said a few weeks ago that'll happen in the very early part of 2023. So we'll keep the name, slightly different font, new color, capital C for care. But
Excellent.
we're excited about it. It'll be,
I like it.
obviously we're very
Congratulations.
focused on innovation, and doing that as a standalone company will be exciting
Focus
for all
on
of us.
patients, focus on clinicians,
Absolutely.
and technology to meet their needs.
Yeah, very, very good. If you're interested in more conversations that we've had GE with some of the new technology that you guys have been doing and more further to this conversation, you do check us out at TopMedTalk.com. We have those from this past summer when we were at ESA, and lots of really great conversations throughout the last year. So do check that out.
TopMedTalk.
Do check us out for our live stream from Anesthesiology 2022, live.topmedtalk.com. You can hear all of our amazing conversations live during Anesthesiology 2022. You can find the schedule for all of those at live.topmedtalk.com. Cheers.